Good evening. I am Francesc Bosch from Vall Institute of Oncology in Barcelona. I'm going to do the seminar on treatment options for the patients with ibrutinib-resistant CLL. So these are my disclosures. During the last 10 years, we had brought in different targeted therapies, alone or in combination, along with the transformation of the therapeutic goals. This enormous progress changed our clinical practice, but also prompt different and challenging therapeutic scenarios. In the following minutes, I will discuss the therapeutic options in a clinical case of a CLL that is double refractory. And the case is a 66-year-old male with a CLL, diagnosed with anemia, stage 3, with impaired renal function, some comorbidities then, and an adverse biological profile because of the unmutated GHB. The patient was treated with venetoclax obinutuzumab because of these comorbidities, and unfortunately, the patient relapsed within 13 months, acquiring TP53 mutation. So how can we treat this patient? In the following table, I'm summarizing the known adverse predictive factors for patients treated with ibrutinib and venetoclax. And you can see that dysfunction of the p53 gene is associated with a short progression-free survival after ibrutinib and venetoclax. So what are the options that we have for this patient? We cannot use chemoimmunotherapy because of the impaired renal function and the p53 abnormality. So we have valid options would be another BTK inhibitor or a PI3 kinase inhibitor. We have little data on the use of BTK inhibitors after venetoclax. Given that these two groups of drugs are acting at different levels, it is expected there is no cross resistance beyond genomic complexity or Richter transformation. The data that we have is usually retrospective and based in real world data. In this table, you can see an interesting real world data published by Anthony Mato, analyzing response to different drugs after venetoclax. You can see that patients that were BTK inhibitor naive had an excellent overall response as opposed to the response observed when we are using PI3 kinase inhibitors. In this publication from the Melbourne group, you can see that BTK inhibitors are effective after venetoclax. So against this background, the patient was salvaged with ibrutinib, and regrettably, the patient developed resistance after 20 months with a complex karyotype and still remain unfit. So between 4 to 30% of patients develop resistance to ibrutinib, particularly those with p53 dysfunctions or a complex karyotype. So the mechanism of resistance are not fully elucidated, but the most of the patients develop mutations in the BTK pathway due to the pressure of the drug. So options in this situation, so we have a patient that is resistant to venetoclax and resistant to ibrutinib. The options are to use an alternative BTK inhibitor, a PI3 kinase inhibitor, or move to a we can call T-cell therapy. We can use a non-covalent BTK inhibitor. These drugs are active in patients with the most frequent mechanism of resistance, which is the mutation of the BTK. Acalabrutinib, that is the other BTK that is approved, is not active in ibrutinib-resistant cases, as the case that we have. And as opposed to the use of acalabrutinib in ibrutinib intolerant patients where ibrutinib is very effective. PI3 kinase inhibitors could be active in ibrutinib intolerant or resistant cases, but with a more modest activity. With a more modest activity, and always with the caveat of the potential toxicity. So we have this new non-covalent BTK inhibitor, pirtobrutinib, that is the results have been recently published. And pirtobrutinib is active in patients that are resistant or are discontinuing ibrutinib. You can see the enormous activity of this drug in the patients that were already pretreated with other BTK inhibitors. So that could be a good option. So finally, we have the use of T-cell therapy. That means CAR-T or T-cell engagers. Those strategies are under investigation. CAR-T-cell therapy is still under clinical trials. You can see here the recent data presented using the liso-cel in patients that were refractory to BTK or venetoclax. A very small number of patients, but it looks like CAR-T therapy is active in this subset of patients. So all in all, in this 66-year-old patient with comorbidities, frail, is unmutated IGHV genes with p53 genetic abnormalities and complex karyotype, and the patient is double refractory to venetoclax plus obinutuzumab and ibrutinib. So my approach would be first to investigate the mechanism of resistance to ibrutinib, and we can do that using two tools. One is to perform a PET-CT to rule out a Richter transformation. You know, if we have an intake superior to an SUV superior to 5 or 6, this is suggesting that perhaps the patient is having a Richter transformation. Therefore, it would be mandatory to perform lymph node biopsy. The other tool that we can use is to analyze the presence of the mutations of the BTK pathway. This can help us to decide to use another BTK inhibitor. For instance, if we have PLC gamma 2 mutations that are downstream the BTK, then the use of another BTK inhibitor is not going to be useful because the BTK pathway is completely active, so we cannot use this kind of drugs. The other thing that I would do in that case is to reconsider comorbidities and therefore the potential use of an allogeneic stem cell transplantation to analyze whether the renal function can be improved, to analyze the other comorbidities, because in this double refractory case, the use of an allo stem cell transplantation, the patient is 66 years old, the use of allo could be a good strategy for this double refractory patient. In the case allo is not suitable, which I think is the case we are discussing, my first option would be to treat the patient with a non-covalent BTK inhibitor, and we have large experience with pirtobrutinib, so my first option in that case would be the use of pirtobrutinib. In case we cannot use this pirtobrutinib or the patient is failing to that therapy, and then I'm going to move to clinical trials, particularly with T-cell therapy, CAR-T, or T-cell engager. We have now very interesting trials. The T-cell engagers, bispecifics, and so on are moving to the CLL field. And we have very interesting trials analyzing CD20, CD3, ROR1, CD3, or CD19, CD3 bispecifics. And that could be an excellent option for this still young patient with CLL. So with that, I'm finishing here, and thank you very much for your attention.